the best evidence that we have in terms of treatment are psychosocial interventions.
Well, hey there, it's Liz Rohr from Real World NP, and you are watching the Real World NP YouTube channel. We make weekly episodes to help save you time, frustration, and help you take the best care of your patients. Hey there. So I have another interview for you. So I'm having Shelby Pope again on the podcast. She is a family nurse practitioner who is now dual certified as a psychiatric nurse practitioner who specializes in addiction medicine and formerly used to work in primary care. So our last episode together, if you missed it, was about substance use disorder, specifically opiates use disorder, like talking about triage and management and things like that. It was a really fantastic episode. And in this episode, we wanted to focus more specifically on first, the topic of how to get a history when it comes to substance use disorder, because I know there's a lot of sticking points for people of feeling like uncomfortable and not sure how to ask and things like that. So we kind of walk you through that piece. And then also after that, we touch on stimulant use disorder specifically, different types, assessment, what are the treatment options, and things like that. So it's a really wonderful episode again. I hope I get to have her on again, actually. She just is such a wealth of knowledge. So I hope you enjoy this interview with myself and Shelby Pope. Thank you so much for being here again. I'm so excited. I guess maybe do like a little intro because I'll link back to the previous episodes, episode that we did together, but just like a brief intro if somebody hasn't watched or listened to the previous episode that we did. Who are you?
Perfect. I'm Shelby. I am a family nurse practitioner and actually just passed my Psych NP boards last week. So dual certified. I am a DNP. I've been a nurse practitioner for going on 4 years now. I've done rural primary care, fell in love with treating substance use disorders, and ended up getting recruited to work at the clinic that I currently work at, which we primarily do addiction medicine and quite a bit of behavioral health because those, kind of align with one another, and we sprinkle in some primary care services. So, yeah.
I love that. Beautiful. And so I loved our last recording. And so this time what we're going to focus on is talking about getting a history for substances that people use. And maybe I can also share a little bit too, because I kind of threw this at you last minute, but kind of like the screening practices and because you've worked in both primary care and addiction medicine. So it's maybe just I think the thing that I'm really trying to get at with this piece of the conversation is that so many people feel really uncomfortable, either asking the questions in the first place, or they don't know what to say or how to say it, or they're worried about offending somebody, or how do I know what to ask for if I don't know what the different drug names are that are out there, the different options, right? So I think that's the main focus of that. And then after that, we'll transition into talking about stimulant use disorder, which I'm very excited to hear about. I'm excited to hear about all of it, but especially that because I don't feel comfortable at all with that. So
no, I'm excited. I'm definitely excited about it. Yeah, so as far as history goes, it's so essential. And I think I mentioned before the camera, I think I take that a little bit for granted. So
totally.
I'm going to let you kind of lead the way, and I'll just kind of tell you what I do and how it goes. Okay.
Perfect. Yeah. So so for example, I guess, and maybe you can also pull back on your experience from primary care. So for example, if you have a patient that's there, and somebody comes in and they're so here's how it worked in primary care. Before, depending on the clinic, they would do a screener, SBIRT screening. And then the DAST, I think, is the other one that I'm thinking of. So the DAST is screening for drug misuse or struggles with drugs. And then the SBIRT was more specific to alcohol use disorder. And so typically that's what we would see is hopefully we were screening people as we ideally screen them at the frequency that we want to. We don't always get into that screening, but I think that there's kind of two entry points. One is you have some sort of screener where you look at the answers and then you kind of ask them versus they're a brand new patient and they come in and you're kind of do you use alcohol? Do you smoke? Do you use drugs? I think that's where people go. But do you have any thoughts about, especially from your experience going from primary care into addiction medicine, if if they're in addiction medicine already, they're ready.
It's an open platform.
Yeah.
Right?
You're already talking about it. But if you're thinking about primary care, especially I think you have such a beautiful vantage point to share with people because you're on the other side of like somebody is already recognizing that they are using substances and it's getting in the way of their livelihood and their quality of life. And then you have people in primary care where they're like either there could be in any spectrum of situation where they're struggling with alcohol use disorder or stimulant use disorder and they don't like haven't talked to any providers yet, or they like actively use and they like we just need to know these things. And I think that like what you were saying before the recording started is like I think we make assumptions about people of whether like, oh, like they're not doing this or they're not using this or whatever. And it's like, you just have no idea what happens behind closed doors of somebody's home. And like, you can make any old assumption. You can learn some wild things that you never expected. And so it's like, I guess that's a place to start is like, if you had a brand new patient thinking back to your time in primary care, because I'm sure it's influenced now by how you ask questions in addiction medicine. Like, what does that look like for you? If somebody comes in, say you haven't done a screener on them, but it's just like, how does that go for you? You're a brand new patient, physical, something like that.
I think so. In primary care, the screeners were definitely essential, specifically because of the limited time frame. So depending on the workflow and how the intro into clinic kind of was set up. But for me, when I was working in primary care, it wasn't uncommon to have kind of a set intake form that I could go through and look at and kind of highlight, oh, these are the red flags. Like this person reported problematic drinking or something. So that obviously would start the conversation. But there's always those outliers, right? Like, so the conversation needs to be had, especially on an initial appointment. And for me, anecdotal experience was I was a like brand new baby nurse practitioner. I think maybe 3 months into the thing, like I barely knew anything. I had a mid-30-year-old male that had advanced cardiomyopathy, had never seen a primary care provider. Really, really sweet guy. And he was there with his significant other. Not like you said before, like you cannot judge a book by its cover, right? Like you just never know. And never in a million years would I have expected that he had an underlying substance use disorder. But with the advanced cardiomyopathy, like things were not adding up. And he honestly ended up passing away from the cardiomyopathy and complications. But during that initial visit, we were going through things and his significant other was like going through this like whole deal. Like I've put him on a plant-based diet. We are exercising. We're only drinking water. I've cut out sugar. And I'm like, golly, this is strange, you know, the way like, and I was looking through the hospital records and nothing was really adding up. And I'm like, any like substance use at all? Like stimulant specifically? Oh yeah, we smoke meth. And I'm like, oh, okay. So I'm like stoked that you're doing plant-based. Exercise is wonderful, but maybe let's work on cutting back on the meth because that's probably the catalyst to the cardiomyopathy. And she was like, oh, you think so? And I'm like, this.
Oh, she didn't know. Oh,
she didn't know.
Horrible.
And this didn't even come up with cardiology. So I'm like, wow. So it was like mind blowing to me. And that really started my interest. And because I had no idea, I'm like, what do you even offer somebody that is a daily meth user? Like I have absolutely no clue what I'm supposed to do here. So that really was kind of an awakening point for me of how it needs to be an open conversation with everyone, no matter how uncomfortable it is. I've seen people on all ends of the spectrum, especially in this setting, but even in primary care, CEOs of large corporations making multi-million dollars a year, actively using substances, struggling with their use, going to rehab. And then I've also seen, the opposite end of the spectrum, generational substance use. But I think across the board, the conversation needs to be had without a doubt. And I think just being open about it. Most common screeners that you mentioned a couple. There's also Cage and Audit. Those are a couple.
Audit. That's what I was trying to remember. Thanks.
Yes. Those come up a lot. But I find anecdotally in the primary care setting, it's wonderful because for the most part, you can build a rapport and you can have these conversation points multiple times. So even if you suspect it, but you're uncomfortable initially, you can kind of build yourself up for the follow-up. Like obviously I would recommend discussing it each time, but if you don't have the confidence to pursue it, like remind yourself, like this is for the greater good. Like I can have the conversation and then just bring it up next time and be like, hey, your vitals every time I see you, or like for alcohol specifically, are just a little bit concerning. Like you appear to be hypertensive, you're a little bit diaphoretic during the appointment, heart rate's high, you look uncomfortable. Some of these things could be signs of withdrawal from either opiates or alcohol, or if you appear agitated and really restless, sometimes that's a side effect of stimulants. So I just kind of want to have that conversation. Like, do you struggle at all, or do you currently actively use? And if you want to have a conversation about it, we can talk about options. And a lot of time, especially in this setting, most people want help. So it's an open platform. Most of my patients don't have any issues talking about it, but in primary care, I think just doing it. You just got to do it.
Yeah. So I think that's like bottom line is just like having those conversations and not making any assumptions. Like I love that. Like I hate that story and I love that story as an illustrative point because like what a tragedy.
Right.
But yeah, I think it's like one of those things that goes under the radar of like how did this get missed by so many providers? Like that's just so heartbreaking. I think I guess thinking about some specifics of like when I think about especially like hopefully we're encouraging people to feel more confident managing addiction in-house. But if we're going to be referring to addiction medicine, like I want to make sure as a primary care provider, I've provided an adequate enough history, as much information as I can present to that person. And so if you're looking for like, in terms of next steps of like, so say I open the door with this patient and I'm like, or like on the DAST or on like any of those screeners, something came up, like what substances are you using? Like, how does that conversation go from there? It's like, what are they using? How much are they using? How frequently? Like, is that all the information typically? Are there other questions that you're asking about like, again, like, I don't feel like I had the fund of knowledge to know what all the different street names are for different substances. Right. So like,
and I don't think they expect that. Like to be honest with you, I think I would appear more foolish if I was like trying to be like, hey,
throwing out all these different words.
What about your ice? Like I think there's a point where they know that I'm like very basic and I'm pretty lame. So I just call it for what it is, and it's fine.
Totally.
Like, I have a great rapport with my patients and they know that I'm dorky. So I think I just have to accept it more than anything. And we laugh at each other and it all works out. But you kind of hit the nail on the head, honestly. I ask about everything. I ask about nicotine. I ask about caffeine. I ask about alcohol. I ask about stimulants, whether it be, I mentioned caffeine, but like cocaine, methamphetamine, opiates, obviously. I ask when they started and kind of what the catalyst to use was.
That's interesting.
For a lot of people in this setting, it specifically for opiates, that it was a lot of times prescribed pain medicine and it just kind of spiraled out of control. For stimulants, I have a ton of patients that had ADHD in childhood or adolescence.
Oh, gosh.
And they aged out of their pediatrician and they could not find a primary care provider that was willing to prescribe them Adderall. And for anyone listening to this that may struggle with ADHD, not having
I was gonna say not really functional without medication.
Yeah, right. And it gets to a point where like people become desperate. And if you've ever been in a place of desperation and if you're in the right setting around the right people or wrong people, and they say, hey, this is a great replacement. Like you can smoke a little meth and you can focus and then again it spirals, so it's in a lot of cases that I experience, it seems like self-treatment for lack of appropriate treatment for ADHD, which we can get into that here in a bit anyways. And then there a lot of it too is depending on the population of people, sometimes it's just like an energy aspect, like people do too much. People need to pay the bills and they can't do it all. Some of my gentlemen that work in really, really like labor intensive jobs, working 13, 14, 16-hour days, like they physically cannot keep up with that and they have a household to support. And to them, it's like, I would rather kill myself on this substance and do it from day, like be able to do these things than stop. And then I have other patients that who it literally is a survival thing. Like people that are unsheltered or unhoused or housing vulnerable, they flat out tell me like, Shelby, meth is not my drug of choice, but if I don't do it every night, someone's going to stab me and rob me and take all my possessions in this world. And it's like, okay, well, let's work on your social determinants of health. let's start there and kind of go down that route.
I want to pause you for a sec. I love
Yeah,
that. Again, like I love the specific anecdotes because I think especially for students, but even like experienced nurse practitioners, it's like nice to see what happens kind of in the real world. But I think like especially like I think what popped in my mind as you were talking about like the history taking in your patients is like there are people who don't want to stop.
right,
And it's for a variety of reasons that we could not imagine.
right.
And so I just love hearing you share that because again, horrible situation, but it's important to hear that it's like just because someone has substance use, like what is that? Oh, I'm losing the name of it, but what is that? Like the motivation, like where they are in that like motivation scale? It's like they're
Oh,
precognitive or
it's like contemplation, like
yeah,
pre-contemplation,
pre-contemplation.
contemplation,
Yes,
action, yes, yes, and
totally. So
maintenance, yes.
totally, totally. And so like there are people who are like, yeah, and there's like I have no interest of going down on that because this is literally a survival thing. And so I think it's so, I just want to put in there that I think it's so important for us, especially even if we feel like so goofy, like doing this wrong, quote unquote, of
Right.
like, as long as we're trying, we're asking the questions, we're like coming from a non-judgmental place of any answer is appropriate. Like
Hmm.
you need to manage your face and how your face
Right.
responds, right? In terms of creating a
Right.
safe, psychologically safe space for somebody. But if you expect so many options and you expect that that's also an option that like, no, they don't want help right now. It's not, we're not judging them. We're not pushing them. We're like, how do we do some harm reduction to keep you as safe as possible? And how do we
Right.
also help with the underlying reasons for the challenges, right? Like you said, the social determinants of health.
Hmm. No, absolutely. And I think, I mean, you hit some really strong points because this is not a space for our bias or our expectations.
Yeah.
We can't help people that are dead. So
Yes.
we need to create a therapeutic space that allows individuals to feel safe and able to come here and be transparent about what they're using, why they're using, and all. I tell people every day, all I'm doing is educating you on the tools that are available, and I want to give you access to them. I am not here to shove them down your throat. I am not here to force you, because more times than not, people that are forced to pursue sobriety
Oh yeah.
don't
Doesn't
stay in
work.
sobriety.
Yeah,
No, no.
absolutely.
So that's, I think the key is understanding the motivations, and then understanding what all they use. Because they're like specifically for stimulants, a lot of people will use opiates as a downer if they're too amped up. And honestly, a lot of the supply around this area, I'm in Oklahoma around the Tulsa area, and it's not uncommon for us to see a contaminated supply with fentanyl.
Yeah.
And there's different theories on that. Some people just say it's a dirty supply or they got a dirty bag. But some there's some assumption that maybe fentanyl is actually being placed in the methamphetamine to create a higher physical dependence, and then there's another argument that maybe the methamphetamine is getting placed in the fentanyl because it's killing everyone and they need to amp it up a little bit. They need to not make that nod so hard.
Oh,
Um,
geez.
so it's kind of like, so that's where the baseline urine drug screen is really beneficial in my setting, which obviously I know in primary care it was very rare we did a urine drug screen unless somebody was being prescribed something controlled.
Yeah.
Um, so that's where it's like essential that you have to have the open conversation and you have to ask specifics. And if people are guarded, while open-ended questions are, obviously the most therapeutic, it's okay to ask specific closed-ended questions if it gets the conversation going. So,
Yeah.
do you use methamphetamine?
Yeah.
Yes or no? Like
Yeah.
it makes them less uncomfortable, and then, you can kind of go
Totally.
that way. But
Yeah, especially when you're volunteering it. Or like, how often do you use meth? It's like it's
right,
just like that's like I'm ready for that answer. I'm not going to be surprised. I'm not leading you to a specific answer of like, oh, of course I don't use meth. I never, right? And then it's like
right.
if we open that door in that psychologically safe space, like it's going to help us get those answers sooner than later, which is going to help us take better care of them.
Exactly. Another specific question would be, preferred route. I always ask
Yeah.
amount too, because that kind of helps. In terms of like drug purchasing, most people do like specifically, since we're going to talk about methamphetamine, I'll just stick to that
Yeah.
just for
Sure.
brevity's sake. Methamphetamine is usually bought in, people talk about grams a lot, and
Yeah.
most people around here like pay like $20 a gram. And then there's a ball, which is like 3.5 grams. So like those are just like terms that a lot of them use. I always ask, like I said, about route. Do you smoke? Do you snort, which is insufflation. Do you inject specifically because they have an increased risk, of infectious disease, hepatitis C, HIV, as well as cardiovascular issues related to infections, like septicemia and bacteremia. And then there's also other routes too. There's parachuting, which is where they put methamphetamine in toilet paper and swallow it. Um, I get mixed reports on that. Some people just prefer it that way, but some of I call them old school stimulant users. They're like, I have no idea why anybody would want to do that. So I'm not sure what the experience is, but that's some people's preference.
Interesting.
And then there's also something called booty bumping, where
Mm-hmm.
people will take the crystal meth and kind of break it down and dissolve it in water, almost like granulated sugar, and kind of do an enema.
Oh, okay.
So that's kind of important to like I just open up like, okay, do you do booty bumping?
Oh, I
And
love that.
um
And you just kind
uh
of lead with that. That's like,
yeah.
yeah.
And it also gives me an opportunity because there's people that have no idea what that is. And then I
Yes.
can educate them and show them that I'm not uncomfortable with talking about their rectum.
Yes.
And then it's like, okay, this isn't so uncomfortable. She's cool with talking
Yeah,
about weird stuff. So,
totally.
um, so yeah, so that's the most common routes. I think I covered everything. Most commonly, what I see is snorting or insufflation, smoking, and injection or IV use. Yeah, that's the most common that I encounter. And then obviously you need to consider, the comorbidities that go with those and targeting harm reduction with that. Um,
Totally.
yeah. And then I think that's trying to think about history, about if there's anything other specific things that I ask. I think we kind of covered a lot of it. The
Yeah.
catalyst to use, the different things that they're using, how often, how much, and specifically what their motivation for use is. I think that's the key. Because if
Yeah.
you don't know what motivates their use, then
Yeah.
it's the cart before the horse.
Yeah.
You
I
got to
love
know why.
that. I love that. That's so, so helpful. And I think like in terms of the amounts, like I think that's still like a learning curve for people. Like I don't think that there's an expectation that you know what all the amounts are. So like how much
No.
meth are you using? Like
Yeah.
I don't use meth. I don't know people who use meth. So like I don't know, but that's something I'm sure that we can all learn as we go in terms
And
of
there's
quantifying that.
nothing as far as the DSM-5 criteria that says someone has to be using a gram a day
Yeah.
to qualify for having a stimulant use disorder,
Yeah.
or any substance use disorder. It's very subjective. It's the amount that they feel is inappropriate. So like,
Yeah.
are you using more than would you like to cut back, or has it taken more than what you previously took to get what you need out of it?
Mm.
Talking about tolerance and talking about withdrawal, like there's no specific quantity or amount to be measured. So that part really doesn't matter too much. It's just like common language of how
Yeah.
people describe it. I remember when I first started, I'm like, I'm gonna have to go Google what a gram is because I don't know what that means. So,
Totally.
but the whole time I'm sitting there with poker face on,
You're
like,
like,
oh,
mhm.
okay, yeah, no problem. 3 grams a day. Got it.
Totally, totally. So hard to, yeah. So like, it sounds like over time you'll get a sense of like how much
Yes.
is one compared to the other kind of thing.
Yes, absolutely.
Um, I love that. Well, do you want to transition into substance use disorder or sorry, stimulant use disorder?
Yeah, let's do it. I think I kind of started off by mentioning, the different types of stimulants. So
So usually
obviously,
meth, yeah, if you want to
yeah,
recap that.
caffeine, nicotine are the really common, but really the ones that are most problematic and have the most what appears to be adverse effects and poor outcomes are cocaine use and methamphetamine use. And those are the most common things that I experience in this setting.
Do you see any
Um,
people who are using like street Adderall
n-
or dextromethorphan? What? No, I'm not saying the
so
name right.
No,
Go ahead.
yes and no. I do see some people that will buy it off of the street and don't have a formal prescription, but it's actually really rare.
Yeah,
I don't know if it's just a geographical thing, but it really
yeah,
seems difficult for patients to get it in around here. So the people that I think are getting it prescribed are like got their claws dug in. They're like,
yeah.
I'm not selling my supply.
Totally.
So
Totally. I
um
guess it's just helpful for, I wanted to ask that because I think that there's a lot of discomfort that providers can have about prescribing. And I hate using Adderall, but the name is too long, the generic. So I'm using
yeah,
the
no,
brand name.
you're
But
fine.
I think that, yeah, I think that some providers feel really uncomfortable with that. So I think it's just nice to hear that it's like, no, actually, at least in your anecdotal experience, right? It's like,
Yeah. Yeah,
Those are not the things.
no, those are not the things that I don't think that's how we should start care.
Yeah.
Like if it, and that's very much practicing defensively. And
Yeah.
I urge people to educate themselves, specifically nurse practitioners, on what that impact looks like whenever we're constantly practicing defensively. Because there's going to be a lot of marks missed in terms of high quality care if we're
Yeah.
constantly doing things because we're afraid of the bad outcome. But ultimately, what ends up happening when you withhold, which in the state of Oklahoma, I can't prescribe a stimulant.
Yeah.
So that it's a Schedule 2, it's not even an option for me, and most nurse practitioners may experience that as well. But um, I see the poor outcomes that come from patients not having access to appropriate treatment for ADHD. And I can confidently say, this is just a personal opinion, but I can confidently say that many of those patients would be better off being appropriately prescribed Adderall instead of being
Yeah.
on methamphetamine and exposed to fentanyl.
Yeah.
So yeah. So don't do that. Don't practice defensively. Give
Yeah.
people
Thank
their
you for
Adderall when
that.
you can.
Thank you for that. But sorry, so cocaine, methamphetamine, those are kind of like the main ones that you're seeing.
Mhm. Yes. So, cocaine, obviously is a natural substance, comes from coca leaves. There could be coca paste. But what we see primarily is cocaine hydrochloride, and most of it is in a powder, but there's also a kind of a rock form, or crack cocaine. Powder tends to be snorted, or injected, but the crack cocaine, same way, it can be smoked because it's very water soluble, and it sublimates in fairly low temperatures. So most people that I encounter smoke it. Methamphetamine, same, almost exact same. As far as benefits from it, people experience a lot of euphoria, increased energy, a lot of motivation. Both cocaine and methamphetamine, just as far as like mechanism of action and how they work in the brain. I don't know if we want to get that deep into it, but just to make
Sure.
people kind of understand
Yeah.
why people love it so much.
Yeah.
They are monoamine neurotransmitter. Um, I'm so sorry. Monoamine neurotransmitter reuptake inhibitors.
Hmm.
And they're non-selective. So they increase serotonin, they increase norepinephrine, and they increase dopamine. Methamphetamine is a little bit more intense, because it has like an efflux as well. So it's just far more saturated and way more potent. So you have this enormous rush of dopamine and
Oh, wow.
norepinephrine and serotonin. And it's important to realize that because I've heard a lot of conversations, as far as case reports about there not being a withdrawal from stimulants, but there
Hmm.
definitely is. If somebody and if you ask any patient that's coming off methamphetamine, they do
Yeah.
not feel well. They're
Yeah.
very depressed. They
Yeah.
have no energy. They want to sleep all the time. So there's without a doubt a withdrawal to that. And that's why, because the synapses of their brain have just gotten so used to being saturated with all these, dopamine, norepinephrine, and serotonin, and then we've just taken all that away. So that's the addictive component of it. And then what else? What else do you wanna talk about? Like
Well, I
I
think
talked
like
about
so.
experience.
Yeah, so I think if you have a patient coming in that's like, I am using meth, I'm using cocaine, like more than I want to, it's disrupting my life. Like, what are the kind of like next steps that you would recommend for primary care people to think about? Like, in the last episode that we did, we talked about like a triage component of like, especially like with opiates specifically, of like, can you be off of this for at least, 20 can you not handle being off of this for more than 24 hours? Then like those people maybe need to go to more of like a rehab versus, so like is there like a triage specific process for stimulant use disorder after you've done that assessment and you're thinking about like how to assist this person in their next steps?
I think if anything, I think it could happen with cocaine, but more so in terms of like severity in terms of acuity. I think it would be more common to encounter overamping with methamphetamine specifically, and that's very subjective. So patients may come in and they're having a lot of palpitations, they're having chest pain, they're having shortness of breath, but that can even go into like people are having seizures. They can be in frank psychosis. So
Mhm.
people mid nurse practitioners that are working in urgent care settings may experience this a bit more, where like somebody's coming in and if they're in frank psychosis, it can be very difficult I will say that, to know if it's an underlying mental health issue or if it's a stimulant. And obviously, in those cases, we just need to refer the patient to the ER for triage and appropriate management. Typically, though, if somebody is like alert and oriented and able to make sound decisions or have a discussion, but they're just like really, really overstimulated and panicking, it's honestly kind of similar to what you would do with someone having a panic attack. You just lower your voice, you can turn down the lights, calm down stimulation, just kind of like, create the therapeutic environment for them, and just kind of let them ride it out. In acute care settings, it's more so like you can do some low doses of benzodiazepines, and then for the psychosis part, pull in psychiatry for sure, because you kind of have to tease out, is this active stimulant, overdose or overamping, or is it schizophrenia or some other psychotic presentation? And if that's the case, then obviously an antipsychotic needs to be brought into the treatment plan. The in terms of primary care setting, I think it's just I love a good algorithm when it's appropriate, and kind of following the steps. So I think the most important part is diagnosing correctly, because if somebody comes to you and they say, I do a little coke on the weekends with friends at a party. I don't think it's an issue. I don't have any issue stopping. It hasn't affected my daily living. I haven't experienced any legal issues. Then that really doesn't meet the criteria for a stimulant dependency, or stimulant use disorder. So you really kind of have to go off of the DSM-5 criteria, which are very easy to find. The big things are like, taking larger amounts over longer periods than intended, persistent desire to use, cravings. I mentioned the tolerance earlier, withdrawal symptoms, legal issues, it's affecting your daily life. And I think there's 11 in total. And then depending on how many yeses you get, so if memory serves me well, 2 to 3 is mild, 4 to 5 is moderate, and anything greater than 6 yeses is considered severe. So you can kind of go off that, and decide, if you're in that severe route and you're just like really nervous about treating this person, hook them up with an addiction medicine clinic,
Cool.
But if you're not afraid to kind of dip your toes in and give it a go, I think stimulant use disorder is a good one, honestly, to affect change ultimately. Because really the best evidence that we have in terms of treatment are psychosocial interventions. There's different types of therapy that you can refer people to. There's the cognitive behavioral therapy. Obviously, most of us know what that is. The matrix model, which a lot of group therapy sessions follow. And then, but specifically one that I want to mention is something called contingency management. Have you ever heard of that? Most people haven't. It's kind of what I call, and this might take away from it a little bit, but it's just how I remember it, the gold star effect. And it's a little bit controversial, but it really does work. And it's where, and it's not really your goals that you set, it's the patient's goals is what I typically recommend. So it could be that the patient sets a goal of like, I just want to show up to my appointments every other week. I want to be consistent with that first. And then if they show up twice in a row, you give them a gas card, or you literally give them a gold star, like something along those lines. And it really does work. It affects the dopamine in the brain, and they're just like, this feels great. And I see it work all the time. I typically use appointment frequency as my contingency management. Like, listen, you won't have to come every week if we can work on cutting down cocaine use, if you want to do that. And it works. They're like, okay, I want to go to 2-week appointments. I'm going to use cocaine once this week instead of twice this week.
That's great.
So it's an easy thing to do. And you can do that in any setting. It doesn't cost a lot to implement something like that. When I was in primary care, I did a contingency management with, I'm going to use a brand name, Long John Silver's, the Bell.
Yeah.
Okay. Yep, I did it with diabetes and weight management. If you met your A1C goal or you lost your weight, you got to ring the bell on your way out, and then the entire office would cheer for you. And it worked and it was exciting for us. If the bell rang, like the whole office would like shout and cheer. Like it was good. It was good. So that's my plug. Get a bell. It really works.
I love that.
It was good.
So I guess like just to paint the picture. So if you have a person, you've done your history, you've done the triage of like how severe are we talking in terms of like the addiction and using that DSM criteria to support us in terms of the criteria. And then when you're talking about setting up the treatment plan, like what does that kind of concretely look like? I mean, is it just kind of a negotiated conversation of like, you know what, I just really want to stop using cocaine, but I'm using it so often, or I'm using meth all the time. What do you kind of concretely guide them to? Like, okay, how much are you using? Do they kind of come up with like, okay, I'll use once less this week or something like that? Like, what does that kind of concretely look like, especially if you don't have, like maybe you refer them to a therapist to start with CBT, cognitive behavioral therapy. But yeah, can you give any sort of insight into like how often do you meet with them? What kinds of conversations are you having? Are there any sort of other pharmacologic, supports for them or sort of like lifestyle behavior things, especially to help with that, like fact that they don't really have those neurotransmitters that they did before? Like, are there any other sort of supports for them?
Absolutely. So typically, kind of like what we learn in nursing school, ABCs. So I always start with the harm reduction, obviously, and understand the comorbidity. So if somebody is using specifically in this setting opioids, including the methamphetamine, I really focus on the opioids, and I talk to them about therapies that we talked about in the previous podcast. And I start there and I make sure that they have Narcan. And anyone that's using anyone that's using methamphetamine, we provide fentanyl test strips so that they can test their supply to prevent overdose, because there are more and more overdose and death related to overdose on methamphetamine because of opiate contamination. So it's really, really important that we reduce harm, because like I said, we can't treat dead people. It doesn't work. So and then we give Narcan to everyone. Obviously, it seems silly, because it's methamphetamine, but it's because of the cross-contamination. So that's first and foremost, comorbidities, figure out what the other, their risk factors are and kind of try to modify those in a way that keeps them as safe as possible so they can continue pursuing treatment. And then the social determinants of health, like we mentioned earlier, because if somebody came into my office and they were unsheltered or vulnerably housed and they were using methamphetamine to stay awake at night, if I said, hey, let's try contingency management. Okay, at best, that's me missing the mark and not providing a therapeutic environment. At worst, it's highly offensive. So obviously be self-aware and understand social determinants of health and impact those, like get case management involved, see where you can help. And then the next step would be the non-pharmacologic, obviously, because, we're trying to be most therapeutic and least invasive. So that would be really do research on contingency management and see how you could implement something like that or refer to some form of therapy. And then the pharmacologic treatments, while there's not really any FDA approved medications for stimulants, there are quite a few that we use off-label. You just have to be really good about documenting and educating the patient about, hey, this is a non-FDA approved medication for stimulant use disorder, but anecdotally, I find that it does help, or there's been such and such study that shows that it's effective for this. For the most, I'm just going to throw them out there, the most common meds. Is that okay?
Yeah.
Okay. Mirtazapine at 30 milligrams per day, it has some norepinephrine stimulation at that high of a dose. It's one of those meds that at lower doses, it could be more sedating. So like
at lower doses is more sedating.
Yes. And that's been, I used to think it was another med, and I may be getting them confused, but I had recently looked this up because I was having a patient who was started on 7.5 of mirtazapine, and they just could not tolerate it because it was so sedating. So then it's like really not helping because they want to use more methamphetamine. But I learned in terms of the data that the norepinephrine stimulation specifically happens more so at the 30 milligram dose. Okay. And there was this study done, and I want to give credit to who it was, but I'm losing, I cannot recall. But it was done, I believe, in San Francisco, and it was a 24-week long study of individuals using stimulants. And they found that there was an increase in abstinence and a stimulant cessation after starting mirtazapine at 30 milligrams. So that's one that I try to do quite a bit. I also really like bupropion. the extended release. There's the 150 dose, there's 300, but really 450 tends to work best in this population.
Oh, wow.
And just an anecdotal thing, the 450 doesn't get covered well by insurance, so I typically have to send in two scripts, the 300 and the 150, in order to get it covered. The most important things to consider is a history of seizures with bupropion prescribing and a history of eating disorder. And it's another one of those things where while a lot of people say it's a contraindication to prescribe bupropion with someone with a history of seizures, you have to consider the risk that these people are putting themselves in by continuing methamphetamine use and potential fentanyl exposure. So I've had cases where it doesn't happen very often, but a person says, I had a seizure because I overdosed on this thing, and they don't have a seizure disorder that's documented. I'll talk to them about the risk, like, hey, if we start this, like, this will lower seizure threshold. We know that to be a fact. So it's potentially going to put you at risk, but they'll be like, Shelby, I'm shooting up meth every day. So it's like, okay, yes, that's fair.
Totally.
So 450 on the bupropion. Anecdotally, what I find though with the bupropion, it primarily helps with abstinence once someone has detoxed off of methamphetamine. I've started it in a few cases where they're actively using, but I don't know that I've noticed any measurable reduction in methamphetamine use. Primarily, it seems like people will subjectively report less cravings and less use. Nothing as far as urine drug screens show that it's completely stopped. My patients, though, that have gone to detox or some sort of rehab or completely quit methamphetamine on their own, and I started bupropion, they respond really well to it. They like it. They say that it gives them energy. They're able to focus, and they seem to do well. Another common one, Vivitrol or injectable naltrexone in shorter frequencies. So there was a study that showed doing that every 3 weeks instead of every 4 weeks showed a reduction. And that's a good one to consider for people using opiates as well, as long as they're not on buprenorphine or on methadone. To consider trying, because it's kind of a double whammy or even a triple whammy if they're drinking alcohol as well. The only downfall of that is it's very, very expensive, so insurance coverage can be a booger. And if they only have stimulant use disorder, I have not experienced getting it covered under stimulant use disorder because it's not FDA approved for that. But if they have those other comorbidities, it potentially could be. But if you're dosing it every 3 weeks, you're potentially going to hit a month where it's not covered. So you kind of have to be careful. And then there's some argument that you can put them on oral naltrexone, high dose 50 milligrams a day, and that might be beneficial, but I haven't seen a lot of data that really supports it. And then lastly, I know I'm forgetting one. I'm forgetting two actually, topiramate. I feel like, did you experience this in primary care? It's kind of becoming the umbrella drug. Like, oh, you've got some evening binge eating. I'm going to give you topiramate. Headaches, topiramate. like topiramate for everyone. And so topiramate's one that that's been studied in a couple of times that shows potentially a less risk of relapse, but not a whole lot of like, I quit meth because I started topiramate. It's more so reduction in relapse rate. But number one, actually recently released in the ASAM guidelines, was prescribing psychostimulants. And the guidelines specifically say, I think I actually put a note on here, and I'm just gonna read that. Yes, so the ASAM guidelines specifically said physician specialists who are board certified in addiction medicine or addiction psychiatry, and physicians with the training, competencies, and capacity for close patient monitoring. They specifically recommended dextroamphetamine, methylphenidate, Adderall were most promising, but at higher doses. The 20 to 30 milligrams a day did not seem to be effective, but 60 milligrams a day did show some decent outcomes. So those are the pharmacologic interventions. And we covered non-pharm.
Yeah.
What am I missing?
No, I think that sounds great. And I guess I just wanted to put in a little disclaimer that probably doesn't need to be said, because most of the people in the real world NP community are very cautious, like overly cautious, as we are when we're new grads. But yeah, just like these are just to like reinforce these are off-label FDA, which
Yes.
depends on your state also. Like if you are allowed to prescribe quote unquote off-label things, it depends on your state regulations, but also the like I would not feel comfortable myself starting a stimulant, pharmacologic stimulant without
Right.
more advanced training. So,
Right.
but I think it's really important for us to hear like what all the options are, and especially if we're motivated to do more addiction medicine, like what are the training and skills that we need to feel comfortable prescribing those things, in addition to like the other measures that we've done for people. So,
Exactly. Yeah. And I think I think having the conversation, at
yeah,
least opening the conversation
yeah,
and getting people into that
yeah,
contemplation phase, like we talked about earlier, is really essential because people start considering like what the landscape could look like without this thing in
yeah,
their life that's potentially a barrier to them being successful in one form or another, if it is, causing a negative outcome. And then they're more willing to come back and have a discussion about, okay, all right, Shelby, what can I do?
yeah,
What's my options? And
totally.
it just kind of goes from there. But no, you're absolutely right. And I think it's probably the culture of the state that live and work in. I do
Yeah,
not feel comfortable prescribing stimulants.
yeah,
But I will say my perception of stimulants has completely changed. I'm not
yeah,
anti-stimulant prescribing. I'm just not comfortable. I don't know.
yeah,
Well, I can't legally, but
yeah,
I think it is very important for people to know what state they work in, what those regulations are, and to know that while the guidelines do say that, it's could be a treatment for stimulant use disorder, it's very important to know that the guidelines specifically say that physician
yeah,
specialist.
yeah,
So we first and foremost, we can't help people if we lose our license. So
yeah.
it's really important to be mindful of that. But
Totally. And I guess what's coming to mind also is like in the conversation for somebody who's like pre-contemplative, for example,
mhm,
like yeah, and I just really want to second what you said about like it really just having conversations plants a seed that you would just have no idea what impact it can have for people.
right.
So I guess it occurred to me also like do you have like a set kind of spiel that you give people when you're talking about um like reasons like the kind of like education for people of like why they might not want to continue using meth if they're like I'm chilling kind of thing, like what are the kind of like risks benefits conversations, like do you have any sort of like set thing that you say for people, or is it any sort of guidance on that piece?
No, that's a great question because I think it's like we said earlier, it's really important to know what motivates them because
Yeah,
if you can't address that motivation, then are you being therapeutic? It's a little bit
yeah,
arguable, you know.
totally.
I think I primarily try to plant the seed of what does the landscape look like without it? Like what could that
Mm.
mean for you?
Oh, I love that.
I have a lot of individuals that desire more, but like can't pass a urine drug screen to get a different type of job, you know? And so we just talk about that. Like, okay, what would be your dream job? If you could wake up tomorrow and you had your dream job, what would it be? And a lot of conversations very similar to that. Like people that have a lot of turmoil in their marriage because of impulsivity or because of like aggressive behavior or fighting a lot. Like Jim, how might that stimulant use impact that? Do you feel like when you're actively using stimulants or on the day that you're smoking, that it's making you more aggressive? What would the landscape look like if you weren't fighting with your wife every day? Like, would that make you happier? Obviously, I can't define that. It's a subjective thing that you have to
Yeah,
define for yourself, but I just kind of wonder what the stimulant plays in this. Um, and then I think that's primarily it, is just knowing, trying to tease out what their motivation is and kind of meet them where they are so that you know how to
yeah.
help.
Totally. That reminds me of I did like a almost like the SBIRT, the brief intervention thing. I can link to these down below, but we did like a practice thing script when they did the like in-service training for it, and it was like I remember two of the questions being like, and being on the receiving end as the quote unquote patient, it just felt really nice where it was just like, well, what do you like about your meth use and what don't you like about it? Because it's like
Yep.
it just gives that possibility. Of like just seeing things as they are. And then I just really love how you just have that vision casting for patients because I like makes me excited thinking about it's like, how is life different? Like, how could things be different? Because then you can hold that vision for them and you can believe in them.
Right.
And like that can help them believe in their own like self-efficacy. So I
Yeah.
think that's really
It
beautiful.
it makes me like honestly choke up because it's it's just really devastating in this setting, like the amount of people that come in and they have no self-worth. Like they do
Yeah.
not recognize the things that they deserve. And I feel like that's like 90% of my patient appointments. Like I just got a
Yeah.
letter actually yesterday from a patient who just talked about his sobriety and how much the treatment has changed his life, and he just wanted to thank me for being his friend and
Oh,
and making him recognize that he was worthy of being sober and having these good outcomes. And he just finished an HVAC program, and he got hired by his teacher. Like he's
I
gonna
love
do great
that.
things, and it's like a lot of times just reminding people like you deserve this. And I also tell
Yeah.
people like I share my experiences too. So I encourage any nurse practitioner that has anecdotal rapport or an empathetic opportunity to pursue that when it's appropriate of like, yeah, I come from generational substance use. Yes, I'm the first person to pursue a college education in my family. Or I have such and such in the system. Like you talk about these things, like, and I tell people all the time, listen, I'm not judging you. I could be sitting on that stretcher tomorrow. So
Yeah.
I'm, I see it enough to know that none of us are above this. So I think, again, meeting people where they are.
That's so awesome. Well, thank you so much again for
Yeah,
being here. This is so fun.
it's been
I love
good.
having you here.
I'm glad. And I really hope that people hear it and just are more comfortable. And that was the whole goal, right? Is just making our
Totally.
primary care peeps comfortable with having the discussion because
Absolutely.
you guys are home for them.
Hmm. Absolutely. Well, thank
You're
you.
welcome.